Hello and welcome everyone to tonight's webinar on dizziness and vertigo. Tonight we will be discussing common presentations such as benign positional vertigo, Meniere's disease, vestibular migraines, post-concussion syndrome, and cervicogenic headaches. I am Dr. Leonie Harcourt, a GP Education Advisor at Capital Health Network. Also with me tonight is Kanal Mohiti, the Events Lead at Capital Health Network, and of course our expert speaker, Physiotherapist Matthew Croger. First, I would like to acknowledge the traditional custodians of the land we are meeting on. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region, and I pay my respects to their elders past and present. I also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. So housekeeping, all participants have been muted. Please type your questions into the Q&A section, not the chat box on your Zoom window. And Matt has kindly agreed to answer questions as they arise throughout the presentation. The presentation itself will be uploaded to the Capital Health Network YouTube page. So if you didn't catch something, you can go back and have a look at the recording. And you're also welcome to share it with your networks. Regarding CPD, please fill out the post-event survey that CHN will send you, and we will also send you a certificate of attendance after the event. And please feel free to self-report 1.5 hours of educational activities to your CPD home. And also just a flag for Health Pathways, which is a free website that you may or may not have heard of or used. And it has guidelines, advice on the treatment and investigations and referral pathways for conditions such as dizziness and vertigo. So now over to our speaker, Matthew Croger. Matt is a very well-experienced physio. He is the director of Capital Clinic Physiotherapy and also the director of Allied Health at the ACT Pain Centre. Matt was amongst the first physiotherapists in Australia to be awarded the title of Australian Physiotherapy Association Pain Physiotherapist, and he has a strong interest in assisting those who have struggled with pain. He believes in identifying all the contributors for an individual's experience and to help them guide them through recovery. So we're very lucky to have him tonight, and over to you now, Matt. Thanks.
Thank you, Leonie. Worst bit of these is always sitting through the introduction, I think, to myself. Those of you thought you might have been done with me, but we've come back for the final in our contributions to the physio series with dizziness. So we might kick straight into it, and just a little bit for anyone that may be interested. And as Leonie said, I'll keep an eye out for questions as we go, so I'll try and manage those myself. So just where we're a little bit up to is, or for those of you that don't know us at all, I've just lost my questions. So there we go. We're primarily based in the city, with our original 2 clinics being the 2 red dots of our city centre and city west clinics. And coming early next year is our 3rd clinic, which is going to be on the edge of Turner, which is going to be in partnership with a couple of other specialist practices, which I can't say a huge amount about because some of that's not my information to tell, but we'll be having our 3rd open there, but it'll be much more focused on how acute care is handled in Canberra. And of course, yes, we have the physiotherapists inside the ACT Pain Centre. I'm lucky enough to help lead the allied health team there under Dr. Ronald Jane. And this is still a prototype, but we've been doing a lot of upskilling with our physios. And in the next month or so, across our original 2 practices, we'll also be learning Canberra Headache Centre, which will also do a fair amount of dizziness as well. So as we cover these things, please feel free to ask questions as we go. I will try and catch them. If I do miss it, I will come back to it at the end. And despite our testing, it's not quite working, but I think that'll work if I put it there. Okay. Sorry, 1 second. So when it comes to dizziness, when it does come to dizziness and vertigo, we aren't really talking about 2 distinct set of symptoms. Dizziness is much more of a global term describing various sensations, which includes lightheadedness and disorientation, and can include things like pre-syncope. whereas vertigo itself is really a specific subset of dizziness. And a lot of what we go through tonight, it is not unusual to see debate around how some of these things are handled or some of the mechanisms involved. So what you're being presented with, I guess, is really my best understanding and what we would do in terms of treatment for certain things. But, you know, as all things in medical, you will find that there are some areas that are hotly debated. So just a bit of an overview of dizziness in general. So dizziness itself is 17 to 30% lifetime prevalence, and with vertigo being more 3 to 10% prevalence, increasing with age. Although, so that's from specific conditions, which does not include things like dizziness from too much alcohol consumption, for example. And we do have multiple causes, of course, which can vary across almost all the systems of the body, from cardiovascular dysfunction, for example, stroke or arrhythmias, neurological dysfunction such as MS, visual dysfunction, psychogenic factors, vestibular system disorders, cervicogenic dizziness, and post-concussion. And it certainly leads to a very high healthcare utilisation, I think often because the vast majority of dizziness, and particularly vertigo, is significantly distressing. And if it is not a usual occurrence, and it leads to people really worrying and fearing what's going on. It certainly reduces quality of life and daily functioning, and then becomes a major risk factors for falls, which is really important in things like BPPV, given that the incidence and the prevalence goes up as we age. So, and we all know the risk factors of falls. So this is, there'll be a couple of wordy slides in here, sadly, but just so we didn't cross too many slides with the same information. But what makes dizziness and vestibular symptoms in general, as well as vertigo, so difficult is there is so much in the way of shared mechanisms amongst all the most common types. So, for example, the vestibular dysfunction and otolith disturbance crosses several conditions. So BPPV being the most common, where the dislodged otoconia causes inappropriate canal stimulation, with Meniere's in the same canals, but is the difference of too much endolymphatic fluid, disrupting the vestibular signaling, and concussion, where the vestibular pathways are affected from the shearing forces that have affected the resultant inflammatory or other pathways that then impair the vestibular ocular reflex. So, you know, we have already, just in that section, we have 3 things that have overlapping mechanisms and need to be differentiated from, which is not always easy. And then we have, when it comes to central integration and sensory mismatch, this pretty much crosses all our dizzy and vertigo diagnoses. So pretty much all of our dizziness can be attributed to a failure of integration of all the information that's coming into the central nervous system, that basically equilibrium or feeling normal relies on almost this predictive ability of expectation of the central nervous system as this is what I'm meant to be able to see. And as soon as we get a mismatch from any of these systems, then the resultant effect is disequilibrium or dizziness. And, you know, that can come from any of these things that are affected, whether it's the vestibular system or whether it's the neck or, you know, whether it's the central nervous system itself in post-concussion syndrome. So it does make differentiation quite difficult, and even, you know, neck mechanisms can cross a lot of this as well. So, you know, in cervicogenic dizziness, we have basically the neck proprioceptors are failing to provide clear information. We're causing that mismatch in the central processing areas. BPPV or Meniere's patients, particularly if it's been recurring or recurrent or chronic, you know, you could imagine frequently get secondary neck stiffening, which then has this overlap that needs to be differentiated during the assessment process, because they're basically trying to hold themselves stiff to minimize the amount of dizziness that they experience. And then there's this overlapping sensory mismatch between neck and inner ear disorders too, that, you know, makes it difficult just to pull apart. Autonomic and psychological contributions, you know, dizziness will, as I've mentioned already, often increases anxiety, and then anxiety can heighten the dizziness, as well as our normal central wind-up mechanisms. So then it could even amplify messages coming from the neck. So, we can see that it can easily start as maybe a primary disorder and move into having contributions from many systems. And then we've got functional or multifactorial dizziness, and which I would say that the vast majority of patients present with more than one contributing mechanism. You have to excuse me if my voice is a bit hoarse. We've just had weeks of the plague in our house. One of the plagues, anyway. Okay. So when it comes to physio assessment in dizziness, that difficulty is why it does take, a really high quality assessment and a high quality reasoning process to try and peel apart what is the most likely dominant mechanism. So we need to be able to assess the vestibular, visual, proprioceptive, cardiovascular, and the neurological systems appropriately in order to differentiate what's what. And no different to any other kind of normal musculoskeletal condition, a significant amount of that will come from the subjective examination. And I do have tables after almost every section in here on how do we differentiate between the things that we've talked about. So hopefully that will be helpful. And then trying to figure out, what came first and then what's potentially a compensatory behaviour. Many of the clinical features that we see are very non-specific, and dizziness itself is not a diagnosis. We want to understand the mechanism. So imbalance, unsteadiness, even nystagmus, nausea, and visual disturbance on their own aren't necessarily specific symptoms. So they might become more specific if we can determine the direction of this nystagmus, or whether it's fatigable or non-fatigable, or what type of movement the nystagmus occurs in. But on their own, they're not necessarily a specific symptom. And so the high quality systematic physio assessment that looks at all of these is what's really necessary to kind of peel apart. And I guess one thing that we're given the benefit of in physio, say, versus a lot of you in general practice, is we have the benefit of time in our consultations to be able to do that, hopefully reasonably extensively. So some of the things that we'll basically focus on today, we'll talk about BPPV, given it's the most common, post-concussion syndrome, vestibular migraine. We'll talk about BPPV and differentiation from things like Meniere's and labyrinthitis. And then we're also going to touch on cervicogenic dizziness. So assessment of these things, and I'll also briefly discuss management of them. So BPPV, I'm sure many of you already know a reasonable amount of BPPV, but this is by far the most common vertigo-based condition. And it occurs when the otoconia, which are calcium carbonate crystals, become dislodged from the utricle, and they enter with the utricle in here, and they enter this posterior canal, right? And by going in and effectively rattling around in there, it disrupts normal vestibular function. And what that does, I've got a picture of this on the next slide, is causes an alteration in the signaling to the central nervous system, which then has a mismatch between things like vision, proprioception things, with the resultant being the experience of vertigo. So important to know that the differentiation with vertigo is that we're talking about basically room spinning dizziness, almost at the level of feeling like you'd have to hold on to something to be able to not fall over. And the most commonly affected canal, because we've got the three canals, is the posterior canal at a prevalence of about 85 to 95% of cases, but it can also involve the horizontal or anterior canal. So when we go through the symptoms, if you're convinced someone has BPPV and something like a Dix Hall pike is not quite provocative enough, or they've had the Epley maneuver and it's helped a bit but not all the way, then perhaps the horizontal or the anterior canal needs to be considered. So as I mentioned, this is quite an old picture, but I liked it because it was one of the few, 1997 Encyclopedia Britannica, believe it or not. So 20 years old, but it actually showed their hair follicles. So the otoconia normally reside inside the utricle in here, and their job is to detect linear acceleration. But what happens when they migrate into the semicircular canals, any of them, but most commonly the posterior, they disrupt the normal endolymph flow through that canal. So they're obviously space occupying, in a small space, and so that's disruptive to the normal flow of fluid. The aberrant flow then causes this inappropriate activation of the hair cells during head movement, and not just that, like that linear activation. And as I mentioned, that mismatch with the other signals that the central nervous system is receiving is what leads to vertigo and nystagmus during positional changes. So, the purists in BPPV would always say that, the observance of nystagmus is pretty necessary for a BPPV. I would say I believe I have seen it without, but one of the things about BPPV nystagmus is that it is fatigable. So depending on, when that had a previous episode, if you haven't seen it, what is the chances that it could have already been fatigable? And that's why it's important during our assessment, which I'll come to, that we try and make our best educated guess from the history of what side we think it is initially, because we don't want to get a false negative when testing what we think is more likely to be the unaffected side. As it can occur on both sides at once, but that would be much rarer than unilateral effect. The most accepted models for BPPV are canalithiasis, so free-floating otoconia within the canal causing disruption, and then capulolithiasis, which is where they adhere to the cupula and basically then cause the disruption at the level of the cupula. So the cupula, you can see that's the zoomed in there, and so that they adhere through here, causing disruption of the hair follicles. And so why is the posterior canal mostly affected? Well, basically, in the anatomical position relative to gravity, it makes it the most susceptible. So if they're in here rattling around, they're just more likely to fall into the posterior canal. Demographics of it. So in terms of incidence and prevalence, so the lifetime prevalence of BPV is about 2 to 3% of the general population. So, in something like Australia, at current population, wherever we're up to, 25 million or whatever, we're going to about 700,000 of those people in their lifetime will experience BPPV. The incidence in the next year is significantly lower than there. The estimates range from somewhere like 0.6 to up to about 1% in that. So that there's about probably 160,000 people in Australia in the next year will experience BPPV. It's the most, as already mentioned, it's the most common vestibular disorder in adults, most frequent in over 50-year-olds, and that's because of the age-related degeneration of the otolithic membrane, which increases the risk of them coming loose and going into the canals. There is a higher female predominance and ratio at about 2 to 1. So that's possibly due to the higher rates of osteoporosis and hormonal factors in women across the lifespan, and recurrence. So after first episode, or within an episode at a point in time, there is about a 15 to 20% of patients within 1 year. So depending on the patient, it is quite common that, particularly if it was posterior canal, that I would teach them the Epley maneuver to be able to do at home if they had a recurrence. Other risk factors. So the vast majority, so in over 50% of cases, it would be argued to be idiopathic. Okay. Other secondary causes include head trauma. Now there's some debate over the timeframes for head trauma on how soon that would need to be to increase the risk. Some state basically any history of head trauma, and I'm like, live in Australia, is who hasn't been smacked in the noggin with a football or had a head clash at some point. But more frequently than not, they talk about head trauma in the previous weeks. History or recent vestibular neuritis or labyrinthitis, history of migraine as well are risk factors. Then we've got the age-related risk factors due to degeneration, and as mentioned, osteoporosis and bone density. And then prolonged bed rest or immobility, recent ear surgery, and other inner ear disorders such as Meniere's. And so in terms of incidence, in the under 40 group, we could get about a 2% incidence in the coming period of time. 40 to 59-year-old age group would be 3 to 10%. And then you can see how significantly increases once we're looking at 60 plus. And if that was broken down even further, the incidence would likely continue to increase. So the summary of that bit is that, who is most affected, and it's adults over 50 years. The most common is posterior canal. Our key risk factors are primarily age, but then trauma and other vestibular infections or migraines, osteoporosis or bed rest. And we should keep in mind that about 15 to 20% will recur within 12 months. So that's a pretty good education point to be discussing with people straight up. So when it comes to the assessment, most of you, I think, would be fairly familiar with the Dix-Hallpike test. Now, what we're looking for in terms of the symptoms of BPPV is that the vertigo associated with it should actually be quite brief, seconds to minutes, and should primarily be with positional changes. So, typically that will be rolling in bed, moving into sitting, looking up or down. So movement of the vestibular apparatus. And then with holding still, that should actually allow it to subside reasonably quickly. That is one of our key differentiating factors toward away from other vestibular or vertigo-based disorders. They can get nausea and vomiting, and then nystagmus is a very key feature. So one thing with the Dix-Hallpike test is you do hear lots of stories of people saying, oh yeah, I've had that test before. They threw me down on the bed so hard and so fast, and and it was quite horrible. It is encouraged to be a reasonably quick test, but I have never found that the speed is overly critical to eliciting the response. You don't want it to be super slow, but you've got to think about that when we've got an aging population, the incidence and prevalence increasing with age, that you're going to get some, reasonably fragile people who you need to do this test on. And so I just say we're going to, move down reasonably quickly. But you will be in control the whole time, and I'm just going to be moving with you. I don't feel that there's a need to kind of fling people down onto the bed. With the Dix-Hallpike, it's just a 45-degree rotation of the neck. You lay them down with their head supported, and then once they're down, you let them fall into that about 30 degrees of extension while still in that rotation. Pardon me. So they don't have to be an extension prior to lying down. A positive test for the Dix-Hallpike, which is for the posterior canal BPPV, is torsional upbeating nystagmus with latency and fatigability. So as it goes, it'll go, 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 and you'll see it slowing down, and it will stop, right? We need to hold this position, so they need to have their eyes open. When you've laid them down, they need to maintain their eyes open so that you can look for the nystagmus, and basically it should settle with holding them in the position reasonably quickly. If you don't get dizziness and nystagmus elicited immediately, you should wait at least 30 to 45 seconds because you can get that latency effect, and that is not uncommon at all. You'll be like, oh no, this is fine, and then all of a sudden, whoa. People react very differently to this with an older population, whether it's for the Dix-Hallpike or the Epley maneuver. If someone is more fragile or they find the vertigo particularly horrible, it is not uncommon for me to have a second person to assist with the positioning in the room. When I know I'm going to do the Dix-Hallpike, if I'm fairly confident, I will also have a towel and a bucket. And then we've got our roll test, which is even simpler, really. It's just less commonly done. And a positive test for that is horizontal nystagmus, either geotropic, which is toward the ground, or apogeotropic, away from the ground. I'm not sure why it's necessary to have these long scientific names sometimes, but there you go. When it comes to the treatment, back to this. So If we're turning our head to the right, we're testing for right-sided BPPV in the Dix-Hallpike test, or the roll test, to be honest, as we lie down there. So because of that fatigability, we are looking in the subjective examination for, what side is it frequently on when they roll, or is it when they turn around in a different direction? What's the movement that seems to provoke it? It's when I get out of bed. So some sort of idea of, well, what position do you lie in to sleep, and then what side of the bed do you get out of, might give us some idea of, which way do they start to turn the mechanism, in order to give us an idea of which side we should test first. This is one of the things that, when it comes to experts, often the evidence on experts is that you try and prove yourself wrong first. This is the kind of thing where we try and prove ourselves right first, because of that fatigability element. And so we don't want to get a false negative on the nystagmus because it's already fatigued. So the various repositioning maneuvers, and there is a test for the anterior canal, and you're just very unlikely to ever need to do it. But basically, the whole intent of the repositioning maneuver is, once we've got that positive test, is how do we get those free-flowing particles to move through the canal and basically be dealt with and reabsorbed into the system. So the positions and the maneuvers are basically designed to help that make its way through the canal to eventually exit the canal, and then the resolution of the dizziness. I do find with the Epley maneuver in particular that it is quite common for people to have higher levels of fatigue for the rest of the day, and they always should have water, and we typically don't get people to we try and get them driven home afterwards. So these are just the various maneuvers with both the barbecue roll, not as delicious as it sounds, and the Epley maneuver. When it's the side that we're going down to is the provocative side, and then interestingly, the vast majority of the movement then turns away from that side. So we want to be able to be good at differentiating, because it is so horrible, what canal is affected, in order to be able to then move forward with giving an appropriate treatment. So one of the most common overlaps would be between BPPV or Meniere's. So reportedly also called idiopathic endolymphatic hydrops, by no one I've ever heard of. And it has a similar presentation to BPPV. And again, some debate over mechanism, but the difference here, rather than the free-flowing particles in the canals, is this increase in accumulation of endolymphatic fluid in the cochlea and the vestibular organ. Okay, again, idiopathic, often associated with autoimmune disorders, tends to be a tendency that is kind of lifelong. And the vertigo and dizziness, rather than being very short-lasting, tends to be 20 minutes to a few days, and can be more associated with things like hearing loss, tinnitus, often sensation of earful, not always vertigo. So not always getting that, but might feel more like constant unsteadiness. A true BPPV, particularly if it's appropriately treated and resolved, shouldn't have this ongoing persistent feeling of like being on the deck of a ship or anything, whereas a Meniere's may be. And the physio role in that is a little bit different, and that is primarily about vestibular rehabilitation, dealing with any secondary things like the therapy for neck stiffness, and then educating on, what are some strategies we can use if they are going through a more significant bout. The core pathophysiology of it is that it's characterized by this increase in fluid and this abnormal accumulation, and it builds up the pressure inside the vestibular organ, which distends the labyrinth. And that distension or distortion, again, still causes that abnormal disruption to the hair follicles. So we've got these overlapping mechanisms just driven by a difference in the initiating factor. Because it is an increase in fluid, that's why we get this more ordinary dysfunction, and the elevated pressure affects the cochlea and impedes transmission through the basilar membrane and can, in fact, damage the hair cells. So you do get some, longer lasting issues with Meniere's across the lifespan. And you also get a loss of potassium homeostasis, particularly if you get a rupture of the labyrinth during severe attacks. And then, when you get the potassium-rich endolymph contacting the perilymph, it causes acute vestibular and auditory dysfunction, a significant hearing drop, and these vertigo attacks. And typically it will be spontaneous, or there are some suggested triggers around dietary sodium, stress, or hormonal changes. So you'll often see people suffering with Meniere's. They're told to be on low sodium diets and things like this. In terms of differentiation, I've just got this here. So typically with BPPV, we're talking seconds to minutes rather than minutes to hours. In Meniere's, the trigger will primarily be head movement or position changes. Meniere's can be spontaneous, not necessarily triggered by movement. Nausea can be common in both, but the nausea and vomiting will be much more associated with the brief bout, and then it'll be fine in BPPV. That's not absent hearing. There's generally no hearing loss in BPPV, generally no tinnitus, generally no ear fullness, whereas we might get variations in that in Meniere's. And imbalance, again, should only be brief in BPPV during the attacks, where Meniere's might be a bit more persistent. The nystagmus should be positional, fatigable, direction fixed, but the nystagmus might just be generally present during an attack of Meniere's rather than being positionally dependent. And the course of BPV is recurrent but brief, whereas you tend to see a progression in Meniere's. And then if we took that one step further and looked at what about differentiating something like labyrinthitis, that labyrinthitis tends to be this really sudden, severe onset that lasts hours to days. So again, it's not always related to things like movement of the head. The trigger is often spontaneous because of the inflammatory process going on. It's not necessarily, again, movement related. The nausea and vomiting is severe and more prolonged. The hearing loss could be present, generally unilateral in labyrinthitis. And again, we get some of these other signs which aren't typically there in BPPV. And imbalance is often severe, and it can persist because there can be some, intermittent or moderate effects ongoing on the apparatus until that's, taught to adapt again. And then the nystagmus should be fairly spontaneous and direction fixed. It shouldn't alter at all, which it can alter in some central nervous system disorders. We've had 2 in the last month at the pain centre who presented with various dizzinesses, and one in a young person turned out didn't seem quite right. So investigation showed in an older person, it showed a cerebellar stroke that hadn't been detected, and in another younger person, aneurysm mechanism. So another one of these things is vestibular migraine. So the definition of this is episodic vestibular symptoms causing vertigo and imbalance, generally associated with a migraine history, even if the headache is absent during attacks. So you don't have to have the headache present with the vertigo symptoms. Prevalence is around 1 to 3% of the general population, and second most common cause of recurrent vertigo after BPPV. The diagnostic criteria around greater than 5 episodes of vestibular symptoms that were moderate to severe, lasting, again, we're talking like minutes to days rather than the briefness of BPPV. Current prior migraine with or without aura, greater than 50% of their episodes have to have migraine features of headache, photophobia, phonophobia, or aura. And again, it's one of these ones with the diagnosis of exclusion that nothing else better explains it. I'll leave that image for the next slide with mechanisms. But why do we see with this migrainous thing, this overlap into the vestibular system? And part of that is because of shared pathways. So this is one of the reasons, and what we'll be doing at Canberra Headache Clinic is why there can also be an overlap with neck mechanisms, because of the shared pathways through the central nervous system. So this trigeminal nucleus, there's multiple subnuclei, like there's cervico-trigeminal nucleus, and there's connections between them both. So you get this increased sensitivity in one of the nuclei, which can be creating increased sensitivity into the connections around it. So basically, with the abnormal integration of it, can increase the sensitivity in those nuclei, leading to an increase in things like neuroinflammatory mediators. And then we get this knock-on effect of where we can get this triggering of over into the vestibular pathways of vestibular migraine. And again, it's always about this sensory mismatch. So what am I receiving from all my tissues? Is that as expected? Do they all match? No. Well, the result is dizziness and disequilibrium. So with the migraine, vestibular symptoms, spontaneous vertigo, positional vertigo, or visually induced vertigo. So we start to see like this broader range of triggers or things that will elicit the response. It would typically have migraine features, but up to about 30% will have dizziness alone. Triggers will tend to be changes in sleep, stress, hormonal changes, foods, or visual overload. And we do see some overlapping with a bit of mimicking of BPPV, given it's a bit of can be a little bit short lasting, Meniere's and anxiety. So that's again where our assessment is going to be really important. In terms of the physio options with vestibular migraine, I have seen this debated around town, but the research is not unreasonable. But our physio options are around education and self-management, vestibular rehabilitation therapy, looking at gaze stability and adaptation exercises. And I'll go through some of these things a little bit later with cervicogenic stuff, balance and postural training, and sensory motor retraining, and relaxation and pacing strategies. The vestibular rehab therapy can sometimes be given a poor name in that because it is provocative and it can be done too vigorously and can make people feel quite unwell. So it's about how do we pick a level that's going to be significant enough to cause adaptation in the system while not making someone too distraught or distressed. And then another mechanism that has, some building evidence is, are there roles with any of these kinds of migraines for using, given that where there's shared nuclei in the brainstem, and it's what we'll be doing at the headache center, are there on top of this ways that we can use the neck to desensitize some of this input and habituate that nucleus to some of the stimulus. Our systematic reviews show that generally the vestibular rehab significantly improved vertigo scores, balance and dizziness, and patients with that patients with migraine progress generally more slowly and are more prone to exacerbation without it. Generally, most of the studies will do it, but certainly none of them recommend doing physio only. That what is really important is that multidisciplinary or interdisciplinary approach of medication, physio, lifestyle, psych support as indicated to deal with these things. So again, if I build on my diagnostic slide, I've removed labyrinthitis and popped in vestibular migraine. That we're down in the minutes, but still, it can be up to the days. That it is less positional, right? Nausea and vomiting is common during episodes, and again, less brief. That there's where the difficulty is there can be transient hearing loss or none, and so that more closely matches our PPPV. And our imbalance might be variable, but again, could persist between episodes. The nystagmus is more typically, will have more visual disturbances than something like a BPPV, so it might be gaze evoked. But then, like a lot of our differentiating factors were around these other symptoms of migraine. And tend to be episodic with variable intervals and also not quite the same demographic. So another common one, or increasingly common one, I think with the building knowledge around it, is post-concussion syndrome, which, to be honest, I think can be one of the most difficult of the lot. And the definition is persistent symptoms beyond the typical recovery period for concussion. And so those symptoms can include headache, vertigo, dizziness, irritability, mood, poor concentration, memory fatigue. About 60% of post-concussive patients have vestibular oculomotor symptoms, which will include various things like, gait or postural imbalances, blurred vision, gaze instability, double vision. So the mechanisms with concussion, just really briefly, across a couple of slides here, is that there's this shearing force across the neuronal axons, and that you get this quite diffuse axonal injury. So unlike something like a direct injury to a nerve where you get a fairly specific disruption in the myelin sheath, which can become an abnormal generating site for impulses, you get this quite diffuse axonal injury, which impairs the connectivity across brain regions because it is so diffuse. And then you get this altered chemical response, lowers their energy production, and then what is essentially neuroinflammation. Pardon me. And then, one of the worst things would be to compound that with a secondary injury before it's fully resolved, because you would just get increase in these things like your neuroinflammation and, a change in regulation of the cerebral blood flow. We will get disrupted sensory motor processing. So because of that diffuse axonal injury, there's impairment in the vestibular cortex. We lose this integration of balance, eye input. Again, it all still comes down to, what is this predictive capacity of our nervous system to kind of say, what do we expect? And then it's not what we expect. So then we get this dizziness. And we just see these more diffuse, I guess, really cross-system symptoms and signs, I should say, that particularly if someone's describing symptoms, you're often going to find signs that cover a bunch of domains. So you'll find cervicogenic contributions, you'll find oculomotor, you'll find autonomic dysfunction. And, compared to all the others, it more than all the others is multi-system, and there is no one-size-fits-all pathology or approach for it. Instead, what we have to do is assess all the domains, which we do in any of these things anyway, but, obviously the main differentiating thing for concussion is the fact that a head trauma has occurred, and if there are no symptoms before that and there are symptoms after, that's our main differentiating factor. So I don't put this into the table that I've been doing up for us. We're looking at symptom onset, duration, triggers, impact on days of life. We've got some good outcome measures now, like the Rivermead post-concussion symptom, the post-concussion symptom scale that we can use to look at symptoms over time. And then our objective assessment, we've got good vestibular oculomotor screens, balance and gait assessments and cervical assessments, that give us all the information we need. So this out of the AIS is, an example of so this is the VOMS, the vestibular oculomotor screen, which involves just a battery of tests that looks at the various systems involved with this processing. So smooth pursuit, the ability of the eyes to move with the head still, and looking at symptom provocation, and looking for things like, we can see different things like catch-up saccades, and looking for not only symptom triggering, but, do we see anything happening around the eyes? We probably don't need to go into this too much, but it's just a battery of the tests. And then, this is not dissimilar to what we would do if we're trying to look at what are the cervical mechanisms involved with dizziness as well. When it comes to the concussion treatment, other than, keeping someone from going back to sport while they're still symptomatic, it will be this components of vestibular rehabilitation exercises, effectively based on the assessment of what you found to be provocative or to be an issue for the patient, that we essentially look to habituate. And, that won't just be doing things like vestibular rehabilitation. If there's those more cognitive effects, it might include things like exposure to noise, reading, so cognitive tasks, things like that, dual tasks exercises, so combining them, vestibular and cognitive tasks, so increasing the challenge for the person over time. And again, the trick is finding that balance between what is mildly provocative of symptoms potentially without causing any increased disability. So just like in the vast majority of cases, we probably don't, need to be causing people high levels of pain from our treatment, like might have been more common in the past. That often there are, subtler ways to get the same effect. But generally, we're looking at how do we habituate the symptoms and the symptoms. So obviously, a lot of this is quite brief overview. But then another condition to differentiate is this cervicogenic dizziness. So, so the definition here is a specific sensation of changed spatial orientation and disequilibrium as a consequence of proprioceptive disorder of the cervical afferents. So this, is most common in something like whiplash or post-concussion syndrome, but you can also see it in cervical spondylosis and chronic neck pain. And the trick with this, when you compare it to something like BPPV, is that it may also be more related to something like movement of the neck. And it will generally occur with those specific movements. Doesn't always have to have neck pain present with those movements. But one of the things with the cervicogenic dizziness, and this overlaps with headache too, is that we're primarily looking at the 3 upper cervical vertebrae, and some of those vertebrae are the richest thing in the proprioceptive fibers that we have in the human body. Like where there's some muscles up there that we're talking about, 3 times the amount of proprioceptive bundles compared to, say, their counterparts in the lumbar spine. So they have a huge proprioceptive capacity, and so they feed a huge amount of information into the central nervous system. And when there's an issue there, we will generally see altered proprioception as well. So when there's a dysfunction in those vertebrae, it causes this alteration of messaging to the central nervous system. Again, that's then not matching the information coming from the vestibular apparatus, or vision, and so it's the mismatch that causes disequilibrium. But that alteration or that dysfunction could then come from a number of mechanisms within the neck. So it could be muscle fatigue or failure of the deep cervical neck flexors or the long cervical extensions. It could be degenerative changes. It could be peripheral sensitization from inflammation in the upper cervical facets. There's a number of mechanisms that could contribute to that. So we can get to cervicogenic dizziness, but then we also want to try and get to a proposed mechanism if we can. Now, most frequently will be neck pain and stiffness, dizziness, lightheadedness, so all our usual things. Could be headaches. There'll be reasonably specific referral patterns for headaches, and we can, unfortunately, get some of these things that have overlap with other things like tinnitus or tinnitus, depending on where you're from. So with our assessment, generally, it's easier if there's a history of neck pain or trauma. We use our Canadian C-spine rules to rule out other things if there's been a trauma, but primarily that is more frequently than not already happened before getting to physio. And then we're looking to rule out our other causes of dizziness or vertigo. Again, if they've had a head trauma, this will often have been done. It'll include a bit of a VBI screen. Our guidelines are still to screen using the positional test for VBI, but they're not very reliable. So, we always play on the conservative side. And then patients will often report those more persistent symptoms like I'm walking on a boat, I feel like I'm bumping into things. It is more that overall persistence of some sort of disruption rather than the instant room spinning vertigo that resolves with staying completely still. Our objective assessment, simple range of motion, palpation. We'll always examine the deep cervical neck flexors, so that will be endurance. It's actually not that necessary to pull out a pressure biofeedback unit anymore. The evidence shows that someone can get a good quality, show my attractive double chin there, contraction in the deep cervical neck flexors when lying down, that the visualization of that is pretty accurate with strength and endurance. And then we've got higher level tests that look at what's the fatigability of that. So being able to maintain that position, lift your head off the pillow for at least 20 seconds without any pain or fatigue is quite normal. So we compare that against normals. Long cervical extensors is the same thing because there's plenty of proprioceptors in them too. So someone should basically be able to lie prone, head unsupported, a couple of kilos on the back of their head and be able to hold that position for 2 minutes without provocation. If they can't, doesn't necessarily, we're trying to figure out, was that fatigue that stopped us or was some other mechanism? And then what is thankfully now is spread out a lot more than it used to be when we started doing this, is what's being taught is this joint position error testing, which looks at proprioception in the neck. So the test is basically someone's lined up with the center, they're trying to feel, where their neck is in space with their eyes closed, and then they try and turn their head 30, 45 degrees back and try and come find their way back to center without looking. And then when we're doing the examination, I would correct them without looking, and we would do a few tests each side, up and down. And we're looking for their ability to be able to come back and find the center. Alterations in if we're thinking cervicogenic dizziness, alterations in proprioception are highly correlated with getting dizziness. And so we know that there's a little bit of debate, but that in normals, the vast majority of people, and most studies say that most people should fit inside our target. The target's not that big. It's not one behind me in this room, maybe about that. And the inner bits about that they should be able to, fall within that. Some studies suggest that normal is to also fall within the yellow, but they all agree that red and beyond is dysfunctional. So if there's that altered proprioception, it needs to be retrained, because that is a suggestion then that we've got altered messaging then potentially contributing to this disequilibrium. And so, yeah, we do this with a laser. And if there is an error there, one of the great things about it is we can just do the same thing, but as a retraining exercise at home. So the person just practices it at home. After every repetition, once they think they're in the center, they open their eyes, they self-correct, and they practice that way. And then they're mostly only limited by, how provocative it is in terms of symptoms. We're looking to differentiate with things. We use most of those visual tests from the AIS. But one thing we really want to try with differentiation is if someone's getting provoked dizziness with something like rotating the head, well, when they rotate the head, they're also moving the vestibular apparatus. So what we want to do is create torsion from below on a spinning chair, often without doing that. And then if we do something like a smooth pursuit test and the symptoms are worsened, then we can hypothesize that there might be a more cervicogenic component, because we've changed the relative position of the neck, but we haven't changed the position of the vestibular apparatus. So increased symptoms during that would suggest that that there'd be more to play in terms of the neck. In terms of treatment, it'll be the various treatments in terms of physio. So proprioceptive retraining is a hallmark of it. If we have altered by, say, a degenerative spondylitic process that maybe has become stiffer over time, then mobilizing and our soft tissue techniques may be appropriate, but we would want to see some reasonable change be able to be attributed to that reasonably quickly. And we certainly want to be complementing it with what are the other dysfunctions. If the dysfunctions are deep cervical weakness or long cervical extensor weakness, then we want to be retraining those fairly immediately, as long as it's not provocative to do so. So strengthening muscles for things like the deep neck flexors, which this is meant to be one in this image, but that's the higher end of exercises. That's probably more of an end stage exercise. And then we incorporate vestibular rehab exercises if necessary with residual dysfunction. So if we come back to the table, almost there, in terms of how do we differentiate with cervicogenic dizziness, again, like BPPV, it's usually brief or positional, but it will have some persistent elements, which is not so common in BPPV. neck movements will trigger it, but so will things like sustained postures, which should be a little different to our BPPV. Nausea and vomiting and dizziness, it's because we're talking more dizziness rather than vertigo. That's a big differentiating factor. And then nausea and vomiting should also be absent or quite rare. And then imbalance, can persist. It's not so brief. Nystagmus should generally be absent unless it was really severe proprioceptive loss, which would usually involve some sort of severe trauma. And there could be neck stiffness and things, which is, it says none in BPPV, but unless it's a bit more secondary or was chronic anyway. But in an older age group, this is where it can become quite difficult, because you can certainly have overlapping neck stiffness and then, of course, degeneration in that inner ear apparatus. And then just a brief touch on things like central causes, is that, that typically they are much more sudden in onset, or a progressive worsening if you've got things like your tumours or your MS. And then probably not going to be quite as episodic like the peripheral causes. With your central causes, so for example, something like aneurysm or something, there's a higher chance of direction changing nystagmus, or like it is vertical or purely torsional, and like it could be gaze evoked. So you might think it's turning in the neck, but it might actually be gaze evoked, and it's nystagmus that doesn't fatigue, unlike in BPPV. And you can get things like the nystagmus without the vertigo symptoms. And then we've also got, your various focal neurological deficits like weakness, numbness, speech changes, double vision, the other more central things, more impaired gait usually, or and things, but typically they will just kind of not present like the others and will just be more unusual. But it's one of those things that, certainly we don't want to miss. So always worth investigating if you have any suspicion at all of a central mechanism. And usually I would probably just flag that, it's not altogether that likely, but we certainly want to rule out some of these more severe things. So in summary, dizziness is multifactorial. Effective management is going to need this quite complex assessment around, what are our primary mechanisms. And common pathologies often have both vestibular and cervical factors, and that, hopefully physio and like those that are trained in dizziness should play a key role in recovery. Certainly with things like posterior canal BPPV, we try and make sure that almost everyone is trained in. We have a number of people who have more training in dizziness, such as, my business partner, Rob Erickson, Anne-Marie McCusker, Matt Chan at the City West Clinic, who've gone and done more dizziness training. And so, they're typically your first ports of call if you want an assessment. But we are generally going to be needing to work together as a team in order to get a satisfactory outcome, whether that's, via medication management or, appropriate investigations via the medical team.
And there's a question down there for you, Matt.
I can see that just now. Right. Patient with dizziness secondary to a traumatic eye injury, damage to the pupil, affecting accommodation asymmetrical pupils. Do you find any of the exercises mentioned for other causes can also help? I wouldn't say I've seen too many, but like I would say that there is a very good chance that you get habituation or compensation of the other visual things, so that I would say that it is possible that they would help. Yes, you would bias the visual ocular, the ocular exercises, and I would think that there would be a certain amount of adaptation and habituation over time, which, to be fair, would probably occur to an extent anyway, but that would probably be accelerated with deliberate practice.
So Matt, what about TMJ and dizziness? That's kind of coming in the cervicogenic area, and muscle tension, and you talk about a multidisciplinary team, so we'd be talking about potentially physios and dental splints, or how would you approach that? That's kind of, I've seen a fair few people with dizziness and TMJ issues.
Yeah, and again, I think because of that shared central processing, so like cervicogenic headache or migraine that might have some component of neck, and TMJ do frequently overlap because of very close shared innovation. Yeah, and I think that gets even trickier to differentiate what's the primary mechanism. So I mean, where you start for someone like that would probably be around what's most bothersome to them. So definitely for things like splinting, particularly for night and things like that, and a physio assessment. There's not heaps of TMJ physios around in Canberra. I mean, so again, Matt Chen, who works with me, who also works at the TMJ Centre, but yeah, it would certainly be not making sure that gets left behind, with a very good assessment for the TMJ as well.
Do you find things like Botox help out with the muscle tensions for the cervicogenic dizziness?
You're putting me on the spot there.
Okay.
Thanks so much, Leonie.
Oh, no, that's
So
an unfair question.
I would say it depends on like what's theorized as the primary contributor, right? So I think this goes into when we're looking at physio in general, as people go, oh, this muscle's really tight. Okay, that's fine. Why is it tight, right? So if something was becoming like secondarily tight because something like it was grossly weak, whether that's from injury or pain or something like that, well, I don't think Botox is probably going to cause is going to give a satisfactory outcome. So you might get some temporary benefit as some of that goes away, but is there a chance that it leaves someone overall worse off? And you have the added complexity of where some of these, well, a significant portion actually of people that get these disorders often have other sensory sensitivity disorders, which might be, other things like IBS, just general tension type headache, other things that have some sort of central wind-up mechanisms that, mucking around can, I mean, I don't think it's that common that it makes people worse, but I think there's a good chance that like the benefit is quite short lasting. Obviously, you can just repeat it. But then you get into the other crossovers is like, then once you've got a high percentage of people with disorders of central sensitivity, then there also tends to be that there are a high percentage of people who have something like neurodivergence, who also then have a high percentage of something like, hypermobility. And if someone's hypermobile, is it appropriate to, particularly around the upper cervical area, to be Botoxing? And I think hypermobility is quite poorly diagnosed.
So basically what you're saying is there is no simple silver bullet for the solution. It is complex, and it is complex.
Yeah, that's a good interpretation.
And what about imaging for the neck? When we send you people, do you like us to image the neck, or if you have any worries about neck issues, will you say, could you image the neck right back to the GP?
I think the vast majority of the time, like, unless there's a red flag, the pathologic changes in the neck are rarely going to be that useful to what you do for treatment. The treatment should be primarily deficit based, and then if there's concern, like imaging can wait. If there's no red flags, imaging can wait, and if there's a reasonable argument. The main thing that I will frequently discuss with people is, we would image if it was going to change the direction of your treatment, or if we're ruling out something that is, would need a significantly different treatment, particularly if that is medical management. But otherwise, that based on the assessment, it's going to be what triggers your symptoms or what's the deficit, and let's deal with that.
Yeah. Thank you so much. If there's no more questions, we'll wind it up there. Thanks, Matt, and thank you for battling through your lingering plague. We really appreciate it. It was extremely thorough, very useful, and really relevant for primary care providers because dizziness and vertigo is such a common presentation for us. Just to let everyone know, we will be putting this webinar on our YouTube page, so you can watch it again. There's some really useful tables there. And we'll send you out an evaluation survey as well shortly with your certificate of attendance. And yeah, very much appreciate all Matt's hard work and input and expertise and wisdom. And thank you very much.